Okay, thank you, and welcome everybody to our Congregation Bethel's program on Dying with Dignity, a Jewish approach to hospice. Tonight's presenters will be Rabbi Renee Tobin. Rabbi Dr. Renee Tobin is both a rabbi and also a hospice chaplain, educator, worship leader, and community liaison. She has over 2 decades of experience in hospice care and communicating with patients and families struggling with the complexities of terminal illness. We'll also be hearing from Dr. Alan Nagazin, has served as a hospitalist in New Jersey, Pennsylvania, and Florida. He's currently medical director and co-founder of Humanitas Health Services, where he has overall responsibility for the medical component of the hospice and palliative program, providing medical oversight for the interdisciplinary team. In that role, he communicates directly with patients and their families, as well as maintaining contact with all medical providers for each patient, ensuring teamwork and continuity of hospice services. And Rabbi David Cantor will also be presenting. Rabbi Cantor holds bachelor degrees in arts and laws from the University of Manitoba and master's degrees in Hebrew letters and rabbinic studies from the American Jewish University. He received his ordination as a rabbi in 2000 from the Ziegler School of Rabbinic Studies, and he served congregations in Manitoba, Maine, Connecticut, Tennessee, California, and most recently and very happily here at Bethel. Rabbi Cantor, would you like to begin?
Thank you. So much of what I have to say we already know and can possibly be said better by others, but thank you for this opportunity to speak. Death is a part of life. We're formed from the earth and we return to the earth. And up until recently, and by recently I mean the last couple hundred years, death was an ordinary part of life. With the rise of modern medicine, and now I'm stepping outside of my lane, the ability to extend life has created a priority on extending life no matter the cost. And death has changed from being something that happened in our homes and in our communities to something that happens in an institution, in a building somewhere else. And with that, there's been a loss of dignity. And so I want to share a story of the death of one of the rabbis who was famous for teaching about death, and also an observation on how the Jewish community approaches death, dying, and mourning. So Rabbi Yehuda Hanassi is one of the greatest rabbis. He was known as Rabbi, and he is the author of the Mishnah. And on the day that he died, the sages decreed a fast, and they begged for divine mercy that he would not die. So the rabbis don't want Rabbi Yehuda Hanassi to die. And so they're fasting and they are praying. And they said, anyone who says that Rabbi Yehuda Hanassi has died will be stabbed with a sword. So we don't want him to die. And don't tell us if he's died, okay? Do not be the bearer of that bad news. Now, the maidservant of the rabbi ascended to the roof and said, the upper realms are requesting the presence of Rabbi, and the lower realms are requesting the presence of Rabbi, right? The heavens, God is requesting Rabbi Yehuda in that he should die and join them. And the people on earth are also requesting. May it be the will that the lower world should impose their will upon the upper worlds. However, she was observant, and she noticed that Rabbi Yehuda was in extreme difficulty. This was in a time when people used to wear tefillin, and they'd wear tefillin not just at morning services, but all day long. And there's a whole section of the Talmud on how you can't take tefillin into the bathroom. So every time you go to the bathroom, you need to take your tefillin off and then go to the bathroom and then come back and then put your tefillin back on. And she noticed how many times he would enter the bathroom, remove his tefillin, and how many times he would put them back on. And she noticed how he was suffering with his intestinal disease. And she said, may it be the will of God that the upper world should impose their will upon the lower world. Let heaven take him. But the sages would not be silent. They are praying and praying and praying and begging for mercy that he should not die. And their prayers are keeping him alive. It's like the rabbinic equivalent of life support machines. And so what does she do? She takes a jug and she throws it from the roof to the ground. It hits with a sound. And in that moment, everyone stops praying and the rabbi dies. So just to make sure that no one else died in the sharing of the news, the sages said to Bar Kapara, go in and ascertain what's going on with Rabbi Yehuda. He goes in, he finds that he has died. He tears his clothing, which is a sign of mourning, but he reversed the tear so that no one would see where his clothing was torn. And he went outside and he said, the angels and the righteous both clutched the sacred ark, and the angels triumphed over the righteous, and the sacred ark was captured. They said to him, has he died? He said to them, you said it, I didn't say it. So that's that story. But what I take from that story is the compassion of the servant who's able to see that he's suffering and doesn't want to see him continue suffering. In all the narratives of the rabbi's deaths, they're never alone. They're always surrounded by people, and they're always being comforted. The Jewish tradition divides comfort and the target of comfort into two places. While someone is still alive, our focus is upon the individual. When the individual has died, our focus is still on the individual and making sure that that person receives a proper burial. And in the preparation for burial, the body is treated as if the soul is still there and treated as with the dignity of a human being. It's only when the body is being returned to the earth that then we shift our focus as a community from the deceased to the bereaved. And then we give them as much love as we can, as much comfort as we can. I hope that in this discussion that we'll have this evening, we will learn about ways to restore the dignity of death and the dying process that may have been lost in recent years in our excitement about just how long we can keep people alive, and return to a place where we're more concerned with what is best for the individual and their comfort and their dignity.
Thank you, Rabbi Cantor. Dr. Allen, would you like to?
Of course. I mean, Rabbi made some very, very good points. And I can basically go off of those points into what I want to discuss. Essentially, I think the term modern medicine is a bit misleading. I think modern is more equivalent with current time, whereas a lot of people interpret modern as possibly advanced or something that is extremely helpful. And I think that's a bit misleading because really from a standpoint of a physician, a lot of modern medicine is very hurtful for the patient. It doesn't necessarily make them feel any better. It prolongs suffering. So I think the more accurate term or the definition for modern would be literally that this day and age, rather than something that is modern and advanced. And what we see a lot of times in the hospital is the conversations with patients and families are severely lacking prior to someone getting hospitalized, somebody already being in advanced stages of illness. And what we hope to do at Humanitas Health Services, what we've kind of based our hospice on, is to try to initiate those conversations at a much earlier stage of the terminal illness process. The current model for hospice, unfortunately, is essentially finding patients that are already hospitalized and getting referrals to hospice, which is really kind of a very, very poor model, because the benefit of hospice is not attained. The benefit of hospice is around 6 months. So with Humanitas, with what I have been doing, what Rabbi Tobin has been doing, what some of our other colleagues have been doing, is trying to initiate that conversation with the community at the community level, physician to physician, which is really not really heard of in the area at all in terms of hospice and palliative care. Physician to physician communication in the community regarding hospice is very poor. So that's kind of a background of what we're trying to do, is to have those conversations at a much, much earlier time, to discuss advanced directives, to discuss planning, to help people really prepare. So that's my intro for now, and I'll let Rabbi Tobin say some words.
Hello, everyone. My role is a rabbi for the Jewish patients and a chaplain interfaith. And ministry at bedside is very important, because we find that support, emotional support, both to the patient and to the family, is critical while the patient is alive. We have a number of staff people. We have a director of nursing who is just genuinely very caring. We also have a professional social worker. We have a pastor that services chaplain needs as well. And we want to get our message out there so that you don't wait until the very end to sign a patient on to hospice. We can offer so many things at an early stage, even when the patient is just requiring palliative care. We can talk to you. Dr. Allen can consult with you, or your own particular medical doctor can talk to you. We service all nationalities. We've done a number of speaking engagements at area congregations to make our program well known. If you have loved ones or family members that are suffering, we urge you to call us at Humanitas and see what we can do for you to expedite the pain and suffering and not make it long lasting for your family members.
Does anyone have any questions at this point? I'd like to make this as engaging as possible for the audience. Sure, go ahead.
I'm sorry, Mary, you have a question.
I had two questions related to this issue of people waiting until very late on to consider, engage with hospice. One, maybe explore the relationship to people's, fear and non-acceptance of death as, a natural outcome of life. And B, on a more economic end, how does that relate to insurance reimbursement? Or people, is there a hang up with insurance reimbursement for this palliative end of life hospice care if it's kind of offered before death is imminent? I'm not sure how insurance relates to that.
Sure. So the first part of your question, the fear associated with hospice, and believe it or not, there have been studies that have shown that this is something that most people actually want to talk about. If you just give me a second, I can pull up a slide here. One moment, just to kind of show you the actual facts and figures. Is the screen sharing enabled? All right. All right, let me see if I can share my screen with everybody. Let's see, okay. Is everyone seeing that?
Yes.
All right. So I'll just kind of go through these quickly. So apologies for my daughter if she's yelling in the background. So we kind of understand that terminal illness is a condition that basically cannot be cured or adequately treated with available medical technology. And it really progresses until it can no longer sustain life, the actual illness. Life expectancy is variable across all types of illnesses. And so, hospice comes in to help manage that. And palliative care is a little bit different because palliative care can help manage chronic illness really at any stage, at any age. So essentially what we're trying to do is improve quality of life. That's what hospice comes down to. It's improving quality of life for the patient with terminal illness. And so, kind of to go back to Mary's question about, the conversation, the timing, we've seen that people that are on hospice earlier actually have a longer survival time than patients that do not receive hospice. Hospitalizations are decreased. And going back to Rabbi Cantor's point, this enables us to hopefully deal with death in the home rather than in a facility. Less ER visits, more time with family and friends, increased life expectancy. And these have been proven to be benefits of hospice that most people are not actually aware of. Some study has shown that receiving at least a day of hospice care can increase life expectancy up to 3 months. And we don't really have to go through the general eligibility for hospice from a medical standpoint at this time. I don't think it's really pertinent. But I wanted to get to Mary's second question, which is here in the slideshow here. So the public's views on end-of-life medical care. So public wants patients and families to have biggest say in medical decisions and doctors to be honest about prognosis. So you can see here that 87% of patients and their families want to have the bigger say in medical decisions, and 88% want their doctors to be completely honest. So the overwhelming majority wants to have this conversation. The problem is that the conversation is delayed and the doctor doesn't initiate the conversation in a timely manner, in the community, that is. And public prioritizes relieving pain and stress over prolonging life. So you can see again that, and these figures are from the Kaiser Family Foundation. So this is a large foundation that conducts a lot of end-of-life studies. 71% prioritize helping people die without pain, discomfort, and stress. Only 19% prioritize preventing death and extending life as long as possible. So again, you ask anyone, on average, more than average, will agree that not having pain, not having discomfort is a priority over living a longer life. Just a little bit more, 7 in 10 Americans have heard at least a little about a hospice. And again, opinions are overwhelmingly positive. So I want to just summarize and get to Mary's point that it's really a conversation that everyone is open to talking about. The fear is I think not as prevalent as people believe it to be. And to get to the second part of your question about paying for hospice, if you have Medicare, then you don't have to pay anything out of pocket. This is covered completely by Medicare. The benefit period is 6 months. So if we can have these conversations earlier, starting at 6 months, it's kind of hard to really initiate exactly at 6 months, but if you or a loved one has a terminal illness and you are of sound mind, and possibly you've seen a specialist that has given you some sort of prognosis, then yes, definitely that would be the time to initiate prior to losing your ability to have that conversation. Once that ability is lost, then things become very difficult. There's a lot of friction, a lot of trauma that the family endures, disagreements. And that is what I see quite often. The preparation is something that, I apologize, sorry, my daughter's in the background. The preparation is something that we do not see as often, and it's quite shocking, actually. So I'll open up the field again for questions or comments. Stop sharing my screen here.
I have the question.
Sure.
Where is the nearest hospice care facility?
So we are mostly a home hospice. So hospice is, delivered in the home. That is the ideal location for hospice. And we have staff that would come to the home, a nurse, a nursing assistant, and to assist with education, with patient care, and things of that nature.
Would the nurse provide sufficient medication to make the patient comfortable, even if it would cause the early death of the patient?
Yeah, so that's a difficult question. So our priority is comfort, for sure. So we do provide medications for comfort. Now, the thought process is that these medications hasten death. That's actually not true. We've seen that even for hospice patients that receive palliative pain management, their life expectancy does not differ much from hospice patients that do not receive palliative pain management.
My experience with hospice care is that I had a friend who was in the hospital. The doctors could do nothing further for that person. They dismissed him. He went home and he had hospice care at home. I think a nurse visited him maybe once or twice a day, changed his diapers, and gave him medication. But what happens when she's not there? Will he have sufficient medication at home to take to control his pain?
Yes, so we do provide patients with medication in the home. We give a certain amount of medication that would, last for, let's say, a week or 2 weeks, and it would just be delivered back to the patient whenever the medication would run out.
Thank you.
Sure. Any other questions or comments? This is an open conversation, so we can.
In that case, what I was wondering is, what happens when the patient is ready for a hospice approach, but perhaps the family members are not and aren't in agreement? Do you counsel them? Do you insist on having? Does the patient have the decision, or does the family member also get a say in this, or how do you resolve and help the family with that?
If the patient is able to make decisions on their own, if they understand their options and are able to communicate back to you their wishes, then that, above all else, is the only person where the decision would come from. If there was a disagreement with the family, then of course, we would provide counseling. We would engage a social worker. But if the patient, you're able to communicate to them, this is what we're doing, and they're able to communicate back to you their wishes and affirm that, yes, that would be absolutely fine, and understand everything that's happening, then that's the final answer. Yes.
I can't help but I don't know, be a little irreverent here, but that's also a good reason to have really good family estate planning and living trusts, and spell everything out so that, you know, your children don't have to disagree with one another or anguish, but like really, really spell it out. And that's what my parents did. And, you know, I think it kept us all united, because otherwise, you know, we 3 kids, we would have had 3 opinions. So I think it's really important.
Absolutely.
Get it
And
notarized.
yeah, and there are interesting case studies about, you know, certain little towns in America where the conversation about estate planning and about advanced measures is, so basically they would do a survey at a doctor's office or at a hospital before the patient would be sick, and they would make this a common thing. I think there was one study in Minnesota, and everyone basically had a plan or advanced measures kind of documented in their medical chart, and they showed that the health outcomes of these towns, of these populations, was far greater than the average of the U.S. population in terms of you know, length of stay in hospitals, ER visits, and just suffering at the end of life. So, I mean, it's a very important conversation to have. Absolutely. Any other questions or comments? Okay, I can share my.
I have one observation, and it's coming from a different world, but we've birthed 5 children, my wife and I, and for the last 2 of them we had a doula, and it's a big difference when you have a guide with you. First of all, they know how to use the equipment that's in the birthing center that is there, but the nurses don't have time to use. But secondly, having a guide who is knowledgeable about how things are supposed to go is helpful. And one would only think that hospice, having someone who is a guide who can say, this is the way things often go, this is what is normal, no, that's what's abnormal. And by the way, you know, I'm not so sure that a feeding tube is a great idea. I think is helpful to have that source of guidance there, rather than just being left on your own with the internet.
100%, absolutely. I saw Arlene's camera pop back on. Arlene, did you want to, did you have a question?
No, I was actually nodding in response to what Rabbi Cantor said in terms of the hospice people being guides. My late father, we had hospice for him. It was very brief. This was like over 15 years ago. And it did come about in the situation you described where the person's in the hospital and, you know, is not going to get well. He had congestive heart failure. So in any case, the hospice people who came to my parents' home, they lived in Florida at the time, were exactly that. They were guides, and my father was on, I guess, medication, palliative care, and they explained what would happen. And even, you know, when they kind of knew it might be his time, they actually kind of knew that, from what I can recall. You know, I think there was somebody there, you know, round the clock. And there was also a chaplain. And, you know, so they had all these, the social worker, the chaplain, the nurse. And even though it was very brief, I think for my mother's sister and me, just that guide, that person who was telling us a little bit of what this was going to be, was very helpful for us. So I'll back up what Rabbi Cantor said with my own personal experience.
Thank you for sharing that. Yeah.
Does hospice ever come into play in the case of extreme pain, chronic pain?
For chronic pain, so that would be the realm of palliative care. So Humanitas is actually, we just became certified. Well, we're a fairly new hospice. We opened our doors earlier this year. We started our process last year. So we are accepting hospice patients. Now, palliative care is the realm of chronic pain, which is something that we are striving to achieve certification in as well. We're not currently taking patients in palliative care, but we will in the near future. Palliative care is an amazing field. I think that it is not really well known.
Yes.
Because what makes it so amazing is that you essentially have an additional layer of care for your chronic illness. It's you have all of the support services that a hospice would have: social worker, physician, nurse, spiritual care as well. And you don't have to wait till your next doctor's appointment. You don't have to wait till, God forbid, your next hospitalization. Palliative care provides you with that extra level of support for any chronic illness that creates any sort of debility, whether it's pain, whether it's inability to, kind of transport yourself or obtain food or, do anything of that nature. It's a way to find solutions for those problems without being alone and without being kind of lost and not knowing what to do. So yeah, that is one of the primary things that palliative care does, is provide pain management for chronic long-term pain.
Okay. Thank you.
Sure. Yes.
Yeah. I have a question for Carol Benderson Leiter. If there's a patient in St. Mary Medical Center who is at near the end of life, the doctors cannot do anything further for the patient, and they're considering hospice care, is there somebody in the hospital, a social worker, who will help that patient and the family to connect with hospice care and give them literature and help with the hospice care?
Yes. And just to, I'm a retired hospital social worker, and that's why Milt asked me that question. Very much so. And I haven't been in the field for a couple of years, but when I left, it was becoming more and more popular. And we had a number of hospice agencies that were available to us. Some families were wary of hospice because they thought there was only home hospice. And although home hospice is certainly the preferred modality, if possible, there are situations where the family just doesn't have the resources to provide the care that's needed at home. My mother-in-law died last year at the age of 103, and she was living at the time of her death in an assisted living facility. And we brought hospice in there, and they kept her so comfortable. The staff was very relieved to have experts who would come in and help them know how to care for her. And it was a very positive experience. My experience as I was, the last years of my working at St. Mary's was that hospice was becoming more and more popular, and that it was being used, the physicians were becoming more comfortable with it, and it was being used much more frequently than it had been a decade ago. So.
Yes. And yeah, and we are also contracted with facilities to provide hospice care in facilities as well. So skilled nursing facilities, assisted living facilities. Yeah.
So Milt, I was just wondering, was your question about St. Mary's related to the possible religious doctrine of certain institutions and being concerned that maybe the line might be drawn differently for end of life decisions? I wasn't sure if that was part of your question.
Is that addressed to me?
Yes.
No, actually, I gave no thought to the religious aspect of hospice care, but I would think that even a Christian hospital would be in favor of hospice care.
Of course.
And,
Yeah.
and just in reference to your question, Mary, St. Mary's many years ago was one of the first hospitals that in the area, and that include the whole Philadelphia area, that allowed termination of life support, in situations where other hospitals would not be comfortable. And I'm talking, I worked there since 1980, so I'm talking years ago. Even though they were a Catholic hospital, I think they were more comfortable being a religious institution because they dialogued about it, and it was just something that they could do because they understood that they weren't always able to, there was no value to sustaining life indefinitely on, for somebody who was not conscious and on a ventilator. But it was a big issue many years ago. And a Catholic hospital was the first one to do it in Bucks County. So.
I was part of a discussion on an ethics committee, and this was about 20 years ago. And the Catholic hospital, and one of the doctors says, we're a Catholic hospital. We believe that when you die, you are welcome to the kingdom of everlasting life. Why should we ever do life-saving measures, right? Once someone's gone, are we not doing them a disservice to bring them back to this world?
Right,
it led for an interesting discussion.
And that's a good point, Rabbi, because we were also the first hospital to have an ethics committee. And when you have an ethics committee, it gives you the means to have those discussions amongst a multidisciplinary staff. And I think that's very important.
Right. And I think what this brings up is just the distinction between sort of allowing nature to take its course, which wouldn't really violate religious precepts, versus, active engagement in like terminating life. And maybe the two rabbis could talk about that distinction and Judaism and so forth.
So you're not allowed to terminate someone's life.
Correct.
But if a person is unable to feed themselves, you're not obligated to feed them. And sometimes there's this notion of unintended result, where if the person is in pain and the dosage of pain medicine necessary to relieve the pain is more than a fatal dose, one can make the argument that we're not interested in the fatal dose, but we're interested in getting rid of the pain and making them comfortable. And that might have an unintended consequence of demise.
That's a very good point. I actually came across an article in the Jerusalem Post I wanted to share with you. Believe it or not, hospice and palliative care in Israel is fairly new. It's newer than it is in the United States. There's an organization, it's called Sohar Through 120. So maybe, Rabbi Tobin or Rabbi Cantor can translate that. Through 120, I understand that. Sohar, I don't really know what that means. But so one of the rabbis that works this organization, his name is Rabbi Yuval Cherlo. So I'm just going to read you a quote quickly. And it kind of relates to everything that we're talking about right now. So he says that normative Jewish halacha is strictly opposed to the idea that we can ever intervene in ways that are intended to shorten life, whether it's directly or indirectly ending a patient's life. But at the very same time, halacha is just as opposed to actively extending a patient's life if they are experiencing significant pain and suffering, unless we know that the patient has specifically instructed their willingness to endure that suffering. And between these two perspectives are a massive spectrum of questions and dilemmas that require experience, insight, and compassion And that's what we're working to provide. So this organization is actually available 24 hours a day, 6 days a week, to help patients and families navigate the questions at the end of life, particularly family members with someone with advanced dementia, where they hadn't prepared to have this discussion previously. So I thought it was very interesting, and I just wanted to share that with you because it was along the lines of what, you know, Rabbi Cantor just mentioned. Anyone else have any comments or questions? I can return back to the presentation if that's of interest. Yeah. Okay. Let me share this again. So to go back to some of the points that a few people brought up about the prevalence of utilization of hospice. So let me just get here. Can everyone see this?
Mm-hmm.
Okay. So hospice is popular, right? So National Hospice Palliative Care Organization data from 2020. So this report indicates that 53.8% of Medicare beneficiaries received the hospice care for 30 days or less in 2018. Now remember, the benefit is 6 months.
Mm-hmm.
So 53.8%. And that's not to mention the other 47% that didn't receive any hospice care at all. A quarter of beneficiaries received care for 7 days or less, which is considered too short of a period for patients to fully benefit from the person-centered care available from hospice. These figures are pretty shocking, aren't they? 50.7% of Medicare decedents were enrolled in hospice at the time of death. So half of decedents in the country that had Medicare were not enrolled in hospice. The median length of stay in the United States is 18 days out of 6 months, which is not enough time to really create any sort of relationship with family or with patients, and to have that conversation, to prepare, and to really ease any sort of suffering. The trauma, there's an inverse relationship between length of stay and trauma for patients and families. The shorter the length of stay, the higher the degree of trauma, whether it's psychological or emotional. So why is there underutilization? And I'll kind of get back to some points that I made earlier. Lack of communication between provider and family. That is the number one reason, is communication. So whether it's with the community physician or whether it's with the hospital physician, sometimes in the hospital, I'll see the same patient come in every 2 months, every 3 months, and I ask myself why. Now, because of the conflict of interest that I have with my hospital, I can't really promote my hospice within my organization. But in the community, there is no conflict of interest. So that is really where the benefit is greatest, is at the community level. So lack of communication between providers and families stemming from lack of time. The hospital system is so overwhelmed now, especially in the primary care setting. You have 15 minutes, and even in the hospital, even less time to see a provider. Lack of knowledge of hospice care among providers. This is still something that is true to this day. Poor prognostication. Prognostication is obviously very difficult. It's not straightforward. And especially with terminal illness, you can't always get the time frame right. You can't always predict correctly, well, this is 6 months or less. But usually in the scenarios that we deal with, it's pretty clear cut. Emphasis on the cure, and that is very prevalent, and insufficient hospice referrals. And that goes from both the inpatient and outpatient setting. So, we've from speaking to physicians in the community, primary care providers, we've noticed a lot of pushback A lot of, I think the pushback has to deal with the lack of knowledge, with a negative connotation associated with hospice. So why discuss it? So as I mentioned, it's decreased emotional, mental, and physical burden for patients and caregivers. And this has all been shown to be true in studies, countless studies that have been done to show the benefit of hospice. Decreased professional burden. So for example, if a family doctor in the community wants to make a hospice referral to me and my colleagues, we take that burden off of their plate and deal with help, and being able to assist the family, the patient with any of the questions they might have, the endless phone calls. So it really is a decreased professional burden for primary care providers, oncologists, cardiologists, and other practitioners with terminally ill patients. And prepares patient and family to deal with the inevitable outcome of terminal illness, which we've touched upon several times already, and meets psychological and emotion needs of patients and their families in a cost-effective manner. So, for example, this can save up to 40% of healthcare costs during the last month of life and 17% over the last 6 months of life. At this point, I'm being repetitive, but our mission is to ensure adequate care at the end of life by working closely with patients. So that's kind of where we stand apart from other hospices, is that we are physician owned, we are physician led, and we engage in physician to physician, physician to family, physician to caregiver, physician to patient conversations, which does not exist in other hospices in the area. And we facilitate these discussions and coordination of care, if necessary, through telehealth or in person. Prepare patients and families for life's most difficult moments through education and support. Rabbi Renee and I, we have already delivered several talks in the community. So, as a physician, I go out there and I give presentations and we have discussions, and we really hope to kind of spread the message in a way that other hospices are not doing. And we engage those most familiar with the patient's medical issues to help create a roadmap for individualized care. So that's really important, because every patient is different, every family is different, every social and psychosocial situation is different. So each situation has to be treated case by case. So vision is to never let anyone deal with end-of-life issues alone. We feel that is completely avoidable and unnecessary. And we are the strong support team that helps enable that. We hope to reduce unnecessary hospitalizations. We hope to collaborate closely with primary care providers and other specialists to achieve smooth transitions and clarify goals of medical care. So I think I'm at the end. I might as well just go through already. And I think on most of these things I already mentioned, that we're uniquely positioned to collaborate with outpatient doctors. We're highly experienced. Rabbi Renee has decades of experience. Suzanne Mayo, our clinical director, has decades of experience. And we provide all of these services at no cost. This is all Medicare. So this would be at no cost to the family or the patient. Therapy if needed, respite care is essentially a period where the demands of care get so great that the patient can be in a facility for a short period of time to give the family some much needed time to kind of recuperate. So a little bit about our other members. So my partner, Len, is a global IT senior management executive. He has 17 plus years of IT experience. And at this point, he has over 10 years of leadership experience. And me, myself, I completed my residency in internal medicine at York Hospital in York, Pennsylvania. And I currently practice hospital medicine at Jefferson Health. And Suzanne, our Director of Clinical Services, she's amazing. I wish she was on the call tonight, but I'm actually taking call for her. She was on call tonight, so I offered to take call for her to give her a break. She's amazing, and I think she went to get a massage tonight, so she's taking it easy. And of course, Rabbi Renee, you know, educator, religious leader, and also decades of experience. This is our information for anyone that, you know, obviously more than welcome to contact us about anything, really. I think that is everything I had on my presentation. Yeah, go ahead.
Yeah. Do you have contracts with local hospitals?
So that is something that we hope to have in the near future. But as of right now, we are not contracted with hospitals. We're contracted with facilities. But I think probably in the near future, that won't be an issue.
Do you have contracts with any local nursing facilities or assisted living facilities?
Yes, we do. I don't have a complete list for you. Suzanne would be able to get you that information, or Len. That's kind of more, you know, on the, although I am an administrator of the hospice, I don't have all that information on top of my head.
Yeah. And one of the reasons I ask is that our experience with my mother-in-law was that we used a facility. We could have chosen any hospice, but we chose the one that was contracted with that particular assisted living facility because they had a lot of staff there, you know, being, you know, and because they had a lot of staff, I think she got a lot more, you know, patient care than she would have had they not had that contract.
Of course, yes, yes. We do have contracts with several in the area. I agree with you. They have their own staff, and our staff goes there as well. So the care is you know, is pretty good.
We've been talking about this more toward the context of like a chronic ailment and assuming that someone is of advanced age. That seems to be the underlying current. But how does the conversation differ when it's more like a catastrophic event and, you know, a bolt from the blue situation? And second, unpleasant topic, pediatric hospice.
Right. Yeah, I mean, I completely agree with you that that's a conversation that we should have. We do not currently provide pediatric hospice. We don't have the experience to be able to do that. I think that's a very specific field that someone that is coming from the pediatric realm, but also somebody that's pediatric trained and, you know, possibly fellowship trained in hospice would be able to provide, and we just don't have that that expertise.
St. Christopher's and Children's Hospital does provide pediatric hospice.
Now, as far as, you know, the other question that you had about if there's a catastrophic event or somebody is a, you know, unfortunate younger age that has to be put on hospice, then of course, you know, we would certainly provide those services as well.
The conversation that you have as providers with families, does that tend to be a tougher conversation because families, it's harder to accept? There hasn't been, you know, sort of mental preparation, or is the difference negligible?
I mean, it depends on the scenario. If, you know, if we are approached to have that conversation, then the conversation tends to be somewhat easier. If, you know, we have to initiate that conversation, which really usually isn't the case because, you know, we are not a palliative or hospice care service rounding in the hospital. You know, we are a community hospice and palliative care. So we are not a inpatient, you know, hospice and palliative care service that has to initiate those conversations with the family. So, you know, by and large, it's the family that really reaches out to us that is already kind of aware that, you know, we really need this service for our loved one. Any other questions? Okay, well, I don't have anything else. If anyone has any other questions, I'm more than happy to answer them.
If not, then I want to thank you all for your comments and contributions tonight. This was incredibly interesting and important conversation, I think, to have. Just to let everybody know, we did record this conversation, this program, so it will be in a couple of days. It'll be on the Beth El website if you want to revisit it for any reason. It'll be on the Adult Ed Archives on the Beth El website.
Great, that's wonderful. I was wondering if it would be, is that video shareable by any chance?
I'll be happy to provide you with a link to it once it's up on the website. So if you want to then share it with anyone, by all means.
Wonderful, thank you.
That's great.
Excellent presentation. Thank you so much.
Thank
All the
you.
best.
This was
Thank you all for joining. Thank you, Rabbi Cantor,
Thank you.
Rabbi Tobin. Thank you so much, Helene.
Thank
for
you, Helene,
organizing
for
it.
everything.
no problem.
Have a
Delighted
good
to have
night,
done it.
everyone.
Good night, everyone. Thank you.
Good night.
Sure. Bye.
Good night. Thank you.
Good night.
You're very welcome.
Okay.
Thank you very much.
You're welcome.
So welcome, Mary.